So welcome everybody who's made it to the end of the conference almost. My name is Lauren Sutherland. I'm an emergency medicine physician at OSU, and I'm here presenting with Annika Banankar, who's a research coordinator at Baylor, and on behalf of both Anita Shari, who's another physician who helped with this project, but also this knowledge is the distillment of a whole year of meetings with our implementation science delirium group. So what we're showing you here is not really our research, to some degree, but it's knowledge from 15 to 20 emergency medicine physicians who are all in different stages of developing delirium programs. So we're going to try to help everyone who's in that pre-contemplative or working on it stage get this information.
Okay, thank you, Dr. Sutherland, for the introduction. So just to start off, both Dr. Sutherland and Dr. Shari receive funding from the National Institute on Aging, but other than that, no financial disclosures to report. So to get right into it, as ED clinicians, you all know what delirium is. We see acute brain dysfunction, but more commonly, this is a patient that you see every shift. We know delirium is incredibly common. About 15% of ED patients present with delirium. And we also know that delirium is also commonly missed in the ED. So 2/3 of patients that present with delirium are going to have those cases missed. And this is incredibly important because we also see that delirium has a higher mortality rate for patients with delirium than for patients without delirium. Delirium is especially common among our older adult population, which represents about 20 to 25% of our total ED cases. And we see that we have tools to detect delirium in the ED, but they're not commonly used. And this is for a variety of reasons. As clinicians, you all know the challenges of working in the ED. We have high staff turnover, competing patient demands, limited resources, ED boarding and crowding, the whole gamut of challenges. And so we're going to kind of go through some of the things that we've learned and some of that importance. So just to kind of re-emphasize the importance of screening for delirium, if we're looking at our total ED population where we have the red and blue patients as being those with delirium, and let's say the red are those that have missed delirium and the blue are those that have identified delirium. A study found that if these patients are discharged, which they found that 20% of these patients are discharged, they have a 6 times higher mortality rate than older adults discharged from the ED that do not have delirium. And so to contextualize that a little bit more, that's double the risk of mortality that patients presenting with a STEMI and treated with a primary PCI have. So it's very important we see increased length of stay and increased mortality for our delirium ED patients. And so here we get to kind of the purpose of this didactic. Hopefully you're attending because you want to screen patients for delirium in your ED or just learn more about it. And as mentioned, it's an incredibly hard place to implement some of these new processes. We have very real-time constraints, stretched-thin staff, high staff turnover, and implementing anything, whether it be a delirium screening or changes to EMR, anything that disrupts workflows or throughputs can be incredibly challenging. So, like Dr. Sutherland mentioned, we're going to be taking some recommendations from our implementation group. We're drawing from QI and implementation science. So this is the consolidated framework for implementation research. And the goal of our presentation is to distill this complex infographic down into some kind of key takeaways for you and your institutions. So the first thing we want to mention is if you're in the pre-contemplation or contemplation phase of ED delirium screening, just know that you're not alone. There are a lot of resources and a lot of people and groups out there wanting to do this work and who are already engaged in this work. So we're going to highlight a few for you. The first is ACEP's ADEPT, Assess, Diagnose, Evaluate, Prevent, and Treat. And they have a variety of resources on structuring delirium screenings, as well as what kind of information is helpful to look for in delirium screenings. The next one is the ED-DEL change package, which has some kind of infographics, flow sheets for your emergency department, as well as explanations for caregivers and patients on delirium. We also have the GEDC, which has a delirium implementation toolkit. GEDC stands for Geriatric Emergency Department Collaborative. And they're kind of a network that can help you make that pitch to your institution about implementing delirium screenings, so you're getting that leadership buy-in as well. And then finally, we have AGEM, which has the Delirium Implementation Group, or DIG, which has an online collection, especially related to EHR and EMR modifications, as well as a variety of other resources. So this isn't an exhaustive list, but it's kind of a good place to get started and know that if you're starting, you don't have to start from scratch necessarily. All right, so now we're going to talk through key steps. The image here is of Dr. Sutherland looking very cheery and chipper in the ER. But if you are not at Dr. Sutherland's institution, which is a level 1 GED accredited institution, if you're not there where she's doing most of the heavy lifting for you, the first step will be assembling your team. And so from our research from the implementation group, we found that leadership buy-in was found to be one of the key facilitators of a successful delirium implementation. It's much easier to do ED delirium screening if it's part of something bigger. So let's say GED accreditation, an age-friendly health system, VA initiatives, participants who were in the process of upgrading or maintaining their ED accreditation also cited that this was like something that was very helpful to know that they had that top-down support. We need leadership or administrative buy-in for training and hiring staff, promoting continuing education, and getting staff on board in general. And that kind of pitch is relatively easy to make just because we can see that we're reducing hospital costs and improving patient outcomes in screening for delirium. So taking advantage of those resources that we've mentioned to make that pitch to your department is really something that can help you later on in the process of implementing that delirium screening. And then the next thing is who's going to be on that team. So different hospitals have different resources, so you may not be able to leverage all of these interdisciplinary team members, but really engaging nurses, physicians, and especially IT in terms of that EMR, EHR modification was something that was found to be really helpful. Because the workflow involves multiple people at different points in a patient's time course, so ED versus inpatient, this is something that's really helpful to establish that baseline in the ED, and if the patient is transferred later on, we have kind of the same screening or the same information that we can carry throughout. The next thing, similar to using your resources, not having to reinvent the wheel and start from scratch, look at what your inpatient is doing. Do they have delirium screenings? What screeners are they using? How are they implementing it in the EMR or EHR? Is it a best practice alert? Is it a flag? What kind of tools are they using to ensure screening adherence, and how are they structuring it? So if they already have a delirium initiative, figure out what they're doing and how you can adapt that to the ED and ED-specific workflows. The last thing I'll mention is having a clinical champion, whether this is a screening champion, a geriatric champion. This was something that was very, very helpful. Clinical champions are kind of the point person to go to, whether it's logistic questions, safeguarding against screening non-adherence or screening burnout, or just questions about best practices. They also can serve as a resource to validate best practices among staff, frontline staff, and leadership. And especially with nursing shortages, having high staff turnover, they're very helpful for that continuing education and answering questions that staff might have about screening. Another thing to mention is that having this champion be longitudinally involved, so over months or years, was something that was really helpful, especially with that staff turnover, and to help motivate people with screenings. The final thing to consider with clinical champions is, depending on your ED, you might want to look at having multiple clinical champions. How big is your ED? Are there multiple pods that are very kind of distinct and disparate? You might want to have one for night shift versus day shift. So those are all things to think about and adapt this kind of model to your own personal institution. And then I'm going to turn it over to Dr. Sutherland to speak a little bit more about her experiences.
Yeah, when we were implementing delirium screening and other geriatric tools into our ED, one of the things we found was we thought we had clinical champions because we had our nurse managers and our nurse educators, but those are administrative champions in the nursing world. And what we really need was boots on the ground frontline nurses for each shift in each area, especially areas like critical care, where sometimes the nursing is shared between multiple nurses, or if you have a front end or quick care area, sometimes these other QI measures don't get done when someone's a level 4 ankle sprain, which never is actually a level 4 if the patient's 65 and older. So you have your team, you have your idea, your leaders say, it's okay, you're good to go, change delirium in my department, and you have to think about how you're going to do that. And patient flow in every ED is a little bit different. What we found was that in smaller ERs that don't have a big backup in their waiting room, it's often easiest to do this in triage in the list of the other things they're doing. But if you work at a big center where you've got 4 or 5 triage bays going, you routinely have 20 to 30 people in the lobby who've been waiting there 6, 7, 8, 9 hours, adding another screen onto the triage nurse burden doesn't work well. And then when we had these discussions with our nurses, the triage nurses felt like this was better for the bedside nurses to know, because the bedside nurse also can do the screening and initiate whatever protocols you have for delirium prevention and management. So there's arguments, you're going to get higher screening rates if you put it in triage, but will you get higher delirium protocol and adherence? We don't know yet. So you have to look at your workflow, involve your frontline staff, and decide where it's going to fit. You also decide who you're screening. Delirium can affect everybody, from little teeny tiny babies with high fevers all the way up to older adults. It's more prominent in our oncologic population, which the age of those patients are getting younger and younger. So do you make it an age cutoff, an acuity cutoff? Decide with your team where you screen, and you can even run simulations with your ED data to see what the burden would be if you make change different cutoffs. You've decided the screening tool, which all have different sensitivities and specificities, and the tool you use is again going to change on where in your workflow you're doing it, who's doing it, and what the outcomes are. And then you also have to consider if you have a large non-English speaking population. So one of the most commonly used screens is the delirium triage screen, and that asks, can you spell the word lunch backwards? Well, if I directly translate that to Spanish, the word lunch is almuerzo, which is a lot more letters, which will be unfair to my Spanish-speaking population. So you have to think about, has the screening tool you've used been validated in the language of that patient? And most of them haven't. And then for your boarding patients, we're lucky if we get someone screened once for delirium in the ED, but if they're boarding 2-3 days, sometimes their risk of delirium goes way up and we're not routinely screening them. So do you need a different thing for delirium screening every shift, every so many hours? You have to decide. Luckily, we have help for you. Our group uses a lot of different electronic health records, and people have built these in already in different ways. And so you can steal what other people have already done and have less of a health IT burden on your team. We have groups that have done flow sheets, dot phrases or templates, order sets, different nudges, icons, best practice alerts. So depending on what your facility likes, you can build these in different ways. And then you might need dashboards for looking at your screening, reporting, and monitoring. So here's an example from our amazing group at the University of Iowa of the delirium triage screen, which I mentioned before. And you can see they ask the patient to spell the word lunch backwards. And then if the delirium screen is positive, it sends a prompt to the ED provider to complete, and the next step, the BCAM. So if you use Epic, you can go into Epic Share and get this. Here's another order set. This one's also out of Epic from our colleagues at Mass General Hospital. And this one I liked because it's not just, okay, they have delirium, what do we do now? It's also the workup for delirium. So think about, do they need a bladder scan? Should we discontinue telemetry or pulse oximetry? What things can we do to help manage and also help evaluate the causes of delirium that sometimes we don't think about as ED providers? We're focused on the chest pain workup, and we don't think, oh, could they also be in acute urinary retention? And then when you're training your staff, you have to convince them to do this. And it's a big problem with motivation and competing priorities. Because one nurse is saying, you want me to click this button for screening when I've got antibiotics over here, this patient is screaming for pain medicine. You know, at any given moment, they are prioritizing their workload. And when do our ED nurses ever truly have a 1 to 4 patient workload, right? These days, the ED is always full, they're always expanding, or they're working mandatory overtime 18-hour shifts, so this is very complicated. And the last thing our staff members want is to have to do something and not see results from it. Don't make me click buttons that don't have any effect on patient care. I'm not going to click just for national reporting or whatever. So you need to engage them. You can engage them with education, teaching them why we're doing this, but you have to, at the end result, they have to see that when they do this screening and tell you, Annika's delirious right now, and then nothing gets done, they're not going to keep screening. But if we have programs where once they're screened, they're positive for delirium, it immediately goes, we get a one-to-one sitter, or maybe she's bumped up on the list for a bed in a hospital, or a bed that's not a cart or chair in the hallway. So if there are ways to tie the delirium screening to actionable things that then help the nurses in their care too, you're going to have more motivation to do it. Other things that you can tie the actions to is EHR alerts. So not necessarily like this person's prevented from leaving, but this person has delirium. Or if they start to walk out, don't just be like, bye, Fred. We need to have someone say, oh, wait, let's talk about why you're leaving and what you need before you wander out acutely delirious. Because let's be frank, we have patients leave against medical advice every single day in the ER. Other actions can be specialized equipment, delirium, agitation devices, sitters, a pharmacy med review. You know, maybe if they screen positive for delirium, it sends a flag to your pharmacy team, hey, do a med rec for me, let's make sure we're not missing anything. So there are ways that, and that takes burden off your nurse too, because often the nurse has to click like, I reviewed the medications and put them all in correctly, which doesn't always happen. Finally, once you put this program in place, you need to evaluate how you're doing, you need to give feedback to your teams, and oftentimes feedback to national organizations if you're doing this for accreditation purposes. We should all be doing it because it's the right thing to do for our patients, but gold stars and nice stickers and signs are good too. So JEDC put together a list of potential process measures and outcomes that you could track. There's a whole bunch of them. The three most important to me are antipsychotic use. So how many of our patients are we medically sedating because of their delirium? Basic delirium screening rates, that should be easy to pull depending on how you build it into your EHR, but are we even doing the screening? Are we overly sedating this population when we could be using non-pharmacologic measures? And then I also think the number of patients that get a one-to-one sitter assigned is really important because that's information you can take back to your ED leadership who, remember, you got the buy-in at the beginning to do this and say, hey, look, we have 20 patients a day who are screening positive for agitated delirium and need a one-to-one sitter, but we only have one sitter in our department. This is not appropriate care. But you can use that data to get you more resources for these staff. I'm not going to say that your hospital CEO is going to prove that to get you more tax and pay for them, but at least you're trying. And you're coming to them with data and reasons. So for all of you, here's a reminder, there are a lot of resources out there. Use what's already been built. I use the management of delirium in the older adults, the emergency department. They have great handouts for family members and caregivers. Your loved one has delirium. While you're here with them, read this. It explains delirium. It tells them things they can do to help out and empowers them. So there's a lot of stuff out there, so you don't have to make it yourself. Beg, borrow, steal, make it as easy as possible, and hopefully sharing my experiences, our experiences, what's worked and what's not worked will help you. So, thank you very much. And half of you are from OSU, so you probably don't have any questions.
Is honestly your nurse feedback and your nurse buy-in, because we do have a lot of competing priorities with sepsis, like everything.
So one thing I didn't mention here is that we also built in exclusions to screen.
Okay.
So sometimes someone's, I just intubated this person, like how am I supposed to do a delirium screen? So we have a too sick to screen. We actually have non-English speaking because we don't have it built in other languages. And then we have, we do our delirium screen before the rest of our geriatric screens, so they can literally put like too delirious to assess fall risk, too delirious to ask about home safety. So we built in those exclusion boxes, and then when I run my delirium data, if they clicked that they couldn't do it and this is why, at least they thought about it, and that I still count that as a positive in our screening data. I did have some nurses that I was tipped off, something like, this person was ambulatory and walking into the bathroom and the nurse clicked all the exclusions for screening, and so I couldn't write my geriatrics note. And so I did, when I ran it, I found that some nurses were just excluding everybody and not doing the screening. Yeah. So we had to have some conversations with specific people about, and it was good. It was education, motivation. But, you know, if a nurse works in a critical care pod, they're going to have a higher rate of exclusions than someone who works in our, you know, level 3s and 4s area. So that was very helpful in empowering them. We also have a lot of patients who come into the ED just for routine dialysis. I don't know if that's something your hospitals do. And so we made an exclusion because we really don't need to ask them all the geriatrics complicated questions 3 times a week, unless they're there for something in addition. So they could click exclusion, routine dialysis. I just saw them 2 days ago. Like,
And what's the information that you give back to them at what rate do you give them?
so when we were really focusing on implementation, I was running a monthly report and giving nursing feedback their particular scores. You saw 18 older adults and your screening rate was 20%. We can work on this. Yeah. But it's hard. Our screening rate is still only like 60 to 65%, even with all of this. We're in. But you can get there. But it takes a lot, and it really takes a lot to change the culture. We also had like, I don't want to do this screening. They came in last night and night shift didn't do it, so why does it always fall on day shift? And so we had to have talks like, okay, but somebody's got to do it. I recognize that, you know, they had triple traumas at 1 a.m. and some things fell through the cracks, but that's what we're here for. And the delirium screening in the morning is even more important because then we can get physical therapy, geriatrics, and everybody on board. So.
Do you have a task that fires every so many hours or something like that?
No. What we did do, we built it in as a patient rounding note. That's what my nurses wanted, so they can double count it as an hourly rounding. So some of them do it when they first get in the room. They like to have everything clean, and it shows up as an undone marker on their track board until they do it. But some nurses, like if they come back in to, you know, hang their antibiotics or something, they'll do it then. Yes, sir.
So I totally agree. It needs a champion, and it sounds like you have a high level of attention as the champion. And I know you're going to be away for a year. What's going to happen to your program?
So I've actually done some de-implementation. So for a while, once we reached sort of a steady state, we're like, okay, we're in the 60-65%. We would have to sit down and really make a bigger push to figure out what we're going wrong to get us elsewhere. I started de-implementing my monthly meetings with our Geri ED team. I would do once a week rounding or little messages from my office like, hey, this person's here for altered mental status and they're 91 and they've been here 18 hours and no one's documented their delirium. Could you do their geriatric screening? So I stopped that for a couple months. We dropped it down to more like 55 to 60%. And so I picked back up some of that. But the nice thing was it didn't drop down to 20%. So I feel like we've changed culture and that they're doing it more. But it is hard. And then the nursing turnover has been very hard. For a while we had lots and lots of travelers, temp workers, and so even though they got that as part of onboarding, it just was hard. So, yes.
I'm curious how this changed your relationship with the hospitalist service, and also recognizing some of the waxing and waning that can occur with delirium, whether or not you kind of had to make adjustments based on that.
So my initial goal was to just get them delirium screened once. But I agree with you, that's a big problem. And my hospital does delirium screening in the ICUs, but not at any of the medical floors. So, and we actually ran the data, it's under review for publication right now, looking at all our ED patients and did delirium, and we do delirium screening, the identifying seniors at risk score, and then we do the 4-stage balance test, which is stand them up and see if they fall down, as our balance testing, because we couldn't get anybody to do the tug. So that's they have to do all 3 to get marked that they had their geriatric screening. And we found that if the screening was done, it doubled to tripled the rate of PT consults, OT consults, and geriatric consults if they were seen in the ED and discharge or ED obs unit. If we admitted them, it didn't change the rate of consultations. And I think part of that is that our EMR changes when you go from one place to another. So the inpatient hospitalist team don't see our screening, they don't see our flow sheets. So if the docs don't write in there, use what's called a dot phrase to put all the geriatric information in their note, like this is their delirium and blah, 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 and this is what I'm doing, then the inpatient team just doesn't do anything about it, and they don't think about delirium upstairs. So that's one of the next things we're looking at is can we make a few floors age friendly? And so we had submitted a grant for that, which got rejected last Friday, but I'm not bitter. But so I think that's having EMRs that can collect this data and have unit-specific flow sheets visible across encounters and across places in the units in the hospital is really important. And the other thing you think of is we do all this work in the ED and then they see their primary care doctor within 3 to 5 days for follow-up, as all people do, and their primary care doctor can't see any of this, right? Like all this stuff we did in the ED is just gone because they don't have that same encounter. So that's another thing we're working on is addressing these systematic EHR issues that are a barrier to continuing this care. But I haven't done it yet. So if you do it, let me know. Okay, thank you, everybody. And extra cheers for Annika, who pitch hit today. So wonderful.